Good morning, everyone. Thanks. So we're going to talk a little bit about cataract surgery and some other intraocular surgical options in patients with keratoconus. Let me try this. Let's see. Oh, did that work? All right, nice. So I think the first thing we should do is talk a little bit about how the eye works in a simplified way. And the easiest way to talk about that is to talk about the camera, or how a camera works, because the eye is in many ways analogous to a camera. There are focusing elements to the eye, similar to focusing elements to a camera, and then there are capturing elements to the eye, just like the film of a camera. And the focusing elements of the eye are two. They are the front portion of the eye, which is the cornea, which is what most of today's talks are focused on, and that's the part of the eye where you're having trouble if you have keratoconus. But there's another focusing element to the eye, and that is the lens of the eye. And the lens is this round structure here which resides behind the colored part of your eye, and the colored part of your eye is called your iris. Okay, so the focusing elements of your eye are two. Light passes through the cornea and the lens and gets captured onto the retina, and then an image is transmitted is captured on your retina here, and an image is then transmitted to your brain through something called the optic nerve. So the lens of the eye is a clear structure suspended within the eye behind the iris, and it functions along with the cornea again to focus images. It's about the size of an M&M candy. In the normal eye, light passes through it, and it's transparent and gets focused to the back of your eye. Here's another picture. And here's a picture showing how light goes through your eye, through the center of your pupil, and images are focused to a point in the back of your eye. So keep that in mind as we go forward. So what's a cataract? Well, a cataract is a clouding of that lens within your eye. It's not a clouding of the cornea, it's a clouding of the lens. And it's very common. Is it a disease? Not really. It's really a degeneration. So when we think about keratoconus is a disease. It's a disease that affects some of you, but cataracts are common to all of us. At some point in all of our lives, we will have some amount of cataract. So it's very, very common. But it can affect people at a younger age, and the statistics are huge. They affect all of us, and as we're all living well older now, many people are having cataract surgery. So the statistics are that about 20 million Americans over the age of 40 have a cataract, and it'll be about 30 million by 2020, and there'll be about 10 million surgeries done a year. It is the most commonly performed surgical procedure in the United States. By 80, more than half of all Americans have cataract or have had cataract surgery. And so here's a picture of a dilated pupil. This is your iris. You're looking through a clear cornea, and here's a cataract. So this is the lens sitting behind the iris that's now become cloudy. And this is it looking at a microscope that you're examined at in the office. And here's the light that is getting partially blocked and shows this round clear structure, which is your lens within the eye. So what causes cataracts? Well, the lens is made out of water and protein, and the protein's arranged in a precise way to keep it clear and transparent. And as we age, some of the protein can clump together, and areas of the lens can become cloudy. When it becomes cloudy, we call it a cataract, but it is the lens of your eye. So what are the signs and symptoms of a cataract? Well, they're very, very similar to the signs and symptoms of keratoconus. Clouded, blurred vision or dim vision, increased difficulty with night vision, sensitivity to light and glare, seeing halos around lights, frequent changes in eyeglasses or contact lenses, and fading of colors, double vision in one eye, and increasing nearsightedness. So who's at risk for cataract? Well, we all are. We all, if we are fortunate enough to live long enough, will develop a cataract. Certain diseases and certain conditions cause earlier development of a cataract, but on average, most people normally are developing a cataract in the range of 60s to 80s. That's pretty common. I would say most of my cataract surgery patients on average are in their 70s. But diabetics develop cataracts earlier. Certain behaviors lead to earlier cataract development. Certain environmental factors, people that are out in the light a lot. Trauma can cause very near after the trauma development of a cataract, and certain medications that many patients may be on, including corticosteroid drops, can cause earlier development of cataract and exposure to radiation. So how do you diagnose a significant cataract in patients with keratoconus? Well, it's actually relatively simple. A thorough examination, including assessing your best corrected vision, oftentimes using a contact lens to determine your best vision in order to determine and try to cancel out that portion of your vision which is due to keratoconus, allows a relatively easy diagnosis of a cataract even in patients with severe keratoconus. So what are your treatment options? Well, just like with keratoconus, your treatment options begin with a discussion about glasses and contact lenses. So when do we do cataract surgery? Well, we do cataract surgery, we talk about cataract surgery really as an option when the vision loss due to the cataract starts to affect your everyday activities, and that's different from one person to another. For instance, a very common complaint for many patients out in New Jersey may be that I have difficulty with night driving, but I see patients in the city who don't care at all about night driving because they don't drive. So it's one of the most common surgeries performed, and it's also one of the safest and most effective types of surgery. The outcomes from cataract surgery versus the surgical risk is really an exceptional risk-reward relationship with cataract surgery. But I should emphasize this, there is absolutely no need to rush, there's no urgency, there's no emergency in general with a cataract. So delaying or waiting on surgery with a cataract does not cause harm and does not affect outcomes or other parts of your eye. What are intraocular lens implants? Intraocular lens implants are lenses that get placed inside your eye at the time of cataract surgery to replace the natural lens that has become a cataract. And you need these because if we don't put a lens inside your eye, you'll need either a contact lens, a strong contact lens, or very, very thick glasses, because the natural lens inside your eye is part of the focusing mechanism of your eye, back to the camera analogy. So intraocular lenses are routinely placed at the time of cataract surgery, and they provide that focusing power. And intraocular lenses now, in the modern era, have the ability to correct both nearsightedness and farsightedness, and in some cases to correct or reduce astigmatism. So there are three general categories, the most common of which is a monofocal or a single focus lens, which is generally correcting your distance vision. Toric lenses are designed to correct astigmatism. We'll talk a little bit about that with keratoconus. And then there are specialty lenses which are designed to correct not nearsightedness, that are designed to correct your close-up vision or your reading vision. So in general, in most cases, we're talking about putting a monofocal lens in people, sometimes a toric lens to correct astigmatism. And then more and more patients are learning about and are discussing the options of having correction of their reading vision as well at the time of cataract surgery. What about keratoconus and cataracts? So a couple things. Can I safely have cataract surgery with keratoconus? What are the unique challenges of having cataract surgery when I have keratoconus? And should I have cataract surgery alone, or should I have it combined with another of the procedures? We talked about cross-linking. Later, Dr. Hirsch will talk a bit about intacs. So let's talk about these separately. So what about safety? Well, there was a study at Wills Eye Institute which looked at cataract surgery in keratoconus patients. This is a small study, but there are many, many small studies with similar results that showed excellent results from cataract surgery even in patients with severe keratoconus with mean corrected vision or best corrected vision. Now, this isn't necessarily without glasses or without contact lenses, because many of you will still need to use contact lenses after cataract surgery, but excellent improvement and excellent corrected vision after cataract surgery. And multiple studies support similar good results. There are some things that you have to consider in keratoconus patients, and one of them is calculating the power of the lens that we put inside the eye. There are many modern ways to calculate the power of the lens to put inside the eye, but generally when we say calculate the power, what we're trying to do is to reduce your need for a glasses prescription or reduce your glasses prescription. Many keratoconus patients are very, very nearsighted. And after cataract surgery, what we're trying to do is when we put a lens inside the eye, we're trying to reduce the need for a very high prescription after cataract surgery. And there have been several modern advances which allow us to still, even in keratoconus patients, calculate this with great accuracy. The surgical view. Sometimes advanced keratoconus patients have a scar in the center of their cornea. Honestly, this is not such a big deal. Many of us that do cataract surgery routinely, this doesn't affect our ability to safely do surgery. I would say that what you should do if you are considering cataract surgery and you have keratoconus is to pick someone that's done a relatively good number of complicated cataracts, and then this generally is not a big deal. The stability of the keratoconus, that is an issue. You should have stable disease before you have cataract surgery. Ideally, you should have stable keratoconus for at least 2 years prior to having cataract surgery. If you don't have stable disease, there should be a consideration of a procedure to stabilize your keratoconus prior to doing cataract surgery, because you will have a better uncorrected result after cataract surgery. We will be able to better reduce and continue to keep you at a level where your eyeglass prescription and contact lens prescription is as low as possible. The cornea is thin in keratoconus patients, and surgically, where to place the wound and how to deal with this comes up, but also is not a significant issue that in cataract surgeons that do a good number of keratoconus patients, and this should not dissuade you from having cataract surgery. The degree and type of astigmatism is something we'll talk a little bit more about when we talk further about whether or not we can reduce some of the astigmatism at the time of cataract surgery. But this is a really exciting thing in doing cataract surgery in patients with keratoconus, and this is the concept of combined procedures where we're doing cataract surgery plus cross-linking or plus cross-linking and intacts. So I talked a little bit about calculations for the lens power that we're going to put inside the eye. Again, we're putting an artificial lens inside the eye to try and reduce your nearsightedness after cataract surgery. And this can be done with really great precision now. And there are actually some new devices which have been around for a few years which allow real-time during surgery reduction and a safety check that the power of the lens that you're going to put in at the time of surgery is correct. In most patients with keratoconus, we're talking about putting in a single focus monofocal lens in order to try and reduce your nearsightedness. And in most cases with keratoconus patients that have a significant amount of irregular astigmatism, they will still need to wear a contact lens in order to correct that irregular astigmatism, which is caused by the cornea after cataract surgery. So if we can click on this, this is I keep trying to show my own video, but my own video for some reason is in black and white. So this is a typical cataract surgery. Cataract surgery generally takes about 5 to 10 minutes. This is making a couple incisions in the eye in order to access the cataract. There's a dilated pupil. This surgeon is peeling open a capsular membrane within that sort of M&M complex of the cataract. And this is an ultrasound probe. And the ultrasound probe causes the cataract to break up into little bits. And aided with a second surgical device here, you're going to see the cataract now crack into a couple pieces. And then he's going to rotate it around so he can access it more easily with his ultrasound probe, which is going to further break up the cataract into little digestible bits. So essentially what you're doing is you're using ultrasound and some physical manipulation to break up the cataract into multiple pieces and vacuum the cataract out of the eye. It's painless. No pain. It's painful. Yeah, it's painless. You're awake for the surgery. You're awake. Actually, anesthetic medication that's used is eye drops. There's an IV placed. It's done in an operating room setting. There's an anesthesiologist present. They give you medicine through your vein to relax you. So it's basically a sedative medication. And people do really well with this without any significant discomfort, either during the surgery or post-operatively. So this altogether takes him about 5 minutes or so to do. And I would say that's pretty typical for a surgeon that operates a lot. What you'll see is after the cataract is fully removed, then there's some remnants that are removed here. These are the softer little bits out on the side. They're removed with basically just a vacuum device. And now what's done, now you're seeing the intraocular lens being placed within the capsule that used to hold your cataract. And that's it. Okay? All right, so let's talk a little bit about astigmatism. And in keratoconus patients, when we're talking about astigmatism, we're talking about the cornea causing most of the astigmatism. In a normal eye, again, that focusing or camera analogy, light's coming through and getting focused by the cornea and the lens together. In the keratoconus patient, light comes in, and when it hits that irregular cornea, it bounces in all different directions, and it still goes through the lens, but it can't be focused to a point like it is in a normal eye. So this is a sort of a nice cartoon video. Can you play this one? Which shows the concept of how light gets bent to a point. So this is an eye without astigmatism. This is how your eye is supposed to work. And next it's going to show an eye with astigmatism and how the light rays come in and can't get bent to that fine point in the back of the eye. Is that still playing? Okay. So this concept of trying to correct some of the astigmatism with a lens placed in the eye, or with an intraocular lens placed in the eye at the time of cataract surgery, has been around for several years and is very, very successful in patients that have something called regular astigmatism. Regular astigmatism is a shape to your cornea which causes that bending of light, but it causes it in a uniform way, which generally is not the case in keratoconus patients. But it may be the case in some keratoconus patients to a certain degree. So in keratoconus patients who have early or mild keratoconus, or have little or no scarring in the center, and are able to have a correction of their keratoconus, mostly with glasses, but not a contact lens, mostly with glasses, then the concept and the possibility of reducing that astigmatism with a intraocular lens comes into play. So why would we do that? Well, you could not only reduce the significant nearsightedness that patients have, you could reduce the significant astigmatism that they have at the same time that you do cataract surgery, and leave them with better vision without glasses or contact lenses after surgery. So let's talk about staged procedures, because I think this is really the thing to talk about if you have keratoconus and a cataract. And the reason to do a staged procedure would be that your stability of your cornea is either not stable, or the cornea itself, the shape of it could sometimes be improved in order to provide you with a better post-operative cataract result. So the first thing to talk about is in patients where the cornea is not stable. And in patients where we're talking about it not stable, we're talking about cross-linking. So if you have a cataract and you have an unstable keratoconus situation, there is no rush to have your cataract removed. And the first focus should be on stabilizing your cornea. It'll lead to a better postoperative surgical result and better intraocular lens measurements. So the first procedure would be to do collagen cross-linking, and then several months later, after the cornea has stabilized, then do cataract surgery. This has the benefit of correcting as much as possible your nearsightedness with a more accurate IOL measurement, and to leave you with something which stays stable over time. If we take out your cataract and you have progressive keratoconus and I put a lens inside your eye, it may be that 2 years later, when you progress further, you have a significant prescription where you didn't have one initially after cataract surgery. And what about the possibility of putting a lens inside the eye where we could reduce the astigmatism? In those patients, in those keratoconus patients, those mild keratoconus patients who have minimal amount of irregular astigmatism, in those patients where we can look on topography and see that most of the astigmatism is regular, there is the possibility of putting a astigmatism correcting lens in the eye at the time of cataract surgery to significantly improve your uncorrected vision after cataract surgery. This is not the majority of keratoconus patients, but this does come up, and certainly there are keratoconus patients where this is a consideration. What about multi-stage procedures? These are interesting as well, because now what we might be able to do is in patients that had, let's say, instead of mild keratoconus, where they had mostly regular astigmatism, let's say they have maybe too much irregular astigmatism, but they could have a corneal ring segment placed and intact, which we'll talk about later, stabilization with cross-linking, followed by potential reduction of their astigmatism, which has now become more regular because we've done something to the cornea, and therefore allows us to place an astigmatism correcting lens at the time of cataract surgery. What about patients that don't have a cataract? Well, most people don't do this, but there's certainly the option, and there's something called phakic IOLs. Phakic IOLs are lenses, intraocular lenses, which are placed inside the eye surgically when you don't have a cataract. And these were developed for younger patients that had very extreme nearsightedness but couldn't have refractive surgery. Keratoconus patients cannot have refractive surgery. So in your younger patient with keratoconus, who again, all the same considerations, has a stable keratoconus situation, but maybe extreme nearsightedness. Let's say they have extreme nearsightedness in one eye, but not the other, or maybe both. You could potentially do a surgical procedure where you implant a lens inside the eye to correct that extreme nearsightedness. They come in two versions. In the United States, in one version. Single focus lenses in the United States, but in Europe, there are astigmatism correcting ICLs. So we call these phakic intraocular lenses. And there are several small reports outside the United States of successful use of these toric phakic intraocular lenses in patients with keratoconus. And just as with cataract surgery, we could talk about single, two, and multi-stage procedures, but you got to go back to stability and mostly regular astigmatism if you're talking about a toric. But let's say we're talking about stability, but just extreme nearsightedness in your younger person. This potentially becomes an option to correct that where refractive surgery is an absolute contraindication. Then finally, instead of putting a lens inside the eye, what if you just did cataract surgery before you develop a cataract? This, again, is rarely done, but is an option in certain patients. And this is called refractive lens exchange. It's essentially cataract surgery, removing the lens of your eye before it becomes a cataract. And this would be for patients that are a little bit older than the patients where we were talking about putting a lens inside the eye. Generally, they're a little bit older because they've already lost their reading vision, and taking cataract out of your eye causes you to need reading glasses after cataract surgery. Same issues with cataract surgery, and this, because you don't have a cataract, is not covered by insurance. Same issues. Could it be a monofocal? Could it be a toric lens to correct astigmatism? Same considerations, 1, 2, or multi-stage procedures. Finally, I'm not going to talk much about this except to say that in patients who have had a cornea transplant or are considering having a cornea transplant, if you have a cataract which is present at the time or develops afterwards, you can have absolutely excellent results with cataract surgery, even if you've had or are considering having a cornea transplant. That's it. Thank you very much.